All right. Well, thank you, Nicole, for being here, and thank you, everyone else, for being here as well. I'm super excited for this topic. And yeah, this is recorded. We'll post it on our YouTube channel later. But again, we'll get started, and Dr. Nicole will hand it off to you.
Sounds good. Hi, everybody. Happy Friday. I am just going to introduce myself real quick, but I know that you guys may have questions as things go along. So I'll just start out by saying that feel free to just hop in and interject. I want this to be interactive. If anything's unclear or you have questions, we'll do question and answer at the end, but also just feel free to jump in anytime because we can just keep this kind of informal. It's Friday after all. So I am Nicole Rowe. I am a family practice physician and I specialize in women's metabolic health throughout the lifespan, but I'm especially interested in metabolic health through the perimenopause and postmenopausal transition. A lot of changes happen during this time, and it is pretty much always a challenging time for women. And I really love supporting women through that transition and kind of helping them navigate all the changes in their body that happen with menopause. So today I'm going to share my screen, but since this is geared towards cancer survivorship, we're going to talk about some of the changes that happen with early menopause, that's treatment-induced menopause, and kind of how we can mitigate those to optimize metabolic health. So I will go ahead and share my screen. Hopefully this works. One second. All right, can everybody see the screen?
Yes.
Okay, perfect. Sounds good. So today we're going to talk about rebuilding strength, energy, and metabolic health after cancer. And what we're going to cover is initially, I'm just going to give a little bit of background about why exactly cancer treatment can lead to early menopause in many cases. Then we'll talk about the role of estrogen in metabolic health and some medical treatment options for improving metabolic health, including HRT. And then we'll go into lifestyle support for metabolic health after menopause, and then leave room at the end for questions and answers. But again, just hop in anytime if you have questions ahead of time. So as I said, I'm a board certified family physician focusing on women's health through the menopause transition. In addition to doctoring, I also do lifestyle coaching. So I have a coaching business and really enjoy just real world practical support for women who are dealing with these changes. Because as we'll talk about, many of the things that we can do for metabolic health are not some magical potion. They're lifestyle things that seem simple on the surface, but they're not always simple to implement. The challenge is being able to fit them into a busy lifestyle and do them consistently. So hopefully we can talk about some of those options here too. But I'll just caveat by saying like none of this stuff is going to be rocket science. The things for metabolic health through midlife are similar to what you may have already heard with exercise and nutrition. It's just kind of fine tuning how to exercise and what that healthy nutrition looks like. Personally, I have not had a history of cancer, but one of my best friends and my medical school roommate was diagnosed with lymphoma in 2015, so about 11 years ago, and she developed treatment-induced menopause at the age of 31. So we obviously talk about that regularly and her experience. And another good friend was diagnosed with breast cancer a few days after her 40th birthday, and she is now in remission and doing well, and kind of managing her symptoms with lifestyle mostly. And she actually had a little bit of a different outcome than my first friend, and her menopause was actually temporary. So why can cancer treatment cause menopause? So the primary problem with, or the primary reason that cancer treatment can cause menopause is usually direct damage to the ovarian follicles, which contain both the eggs as well as the surrounding hormone-producing cells. So the follicle is the functional unit of the ovary, and many chemotherapy agents directly damage the DNA And eggs are particularly vulnerable because they can't repair DNA damage as easily as other cells do. And so if enough damage occurs, the follicle will undergo programmed cell death, and just kind of cause itself to die. Um, and so as the follicle pool declines and these eggs are undergoing programmed death, then naturally estrogen production starts to fall, as well as anti-Mullerian hormone and inhibin B production. So then the brain senses this, and then when the ovarian function is decreasing, the hypothalamus, which is part of your brain, reduces more hormones, including FSH and a little bit of LH, and then FSH rises because essentially your brain is trying to stimulate ovaries, but the ovaries are no longer responding adequately. So if you get hormones tested during this time, it would be characterized by a low estrogen level and at very high FSH because your brain is trying to stimulate the ovaries. In contrast, some people are prescribed leuprolide as adjunct to their treatment, especially when their goal is preserving fertility. And so leuprolide works a little bit differently. It kind of just shuts everything down, including the production of FSH and LH and estrogen. So it's essentially kind of turning everything off. And so the hormone levels will look different on blood work. Um, so this, I'm going to just skip over this because we just talked about that, but leuprolide is sometimes used in hormone receptor positive breast cancer, for ovarian suppression for women who want to try to preserve fertility. Okay, so then getting into breast cancer specifically, aromatase inhibitors, which are often prescribed as part of cancer treatment, can often cause menopause-like symptoms, such as hot flashes, as well as the metabolic changes we'll talk about, which will usually go away once the medication is stopped. Um, and then sometimes tamoxifen is prescribed depending on your cancer regimen. On average, that can cause hot flashes, but doesn't tend to cause quite as severe of menopausal symptoms overall, because it's a selective estrogen receptor modulator. So it blocks estrogen in some tissues and then it mimics estrogen in other tissues. Um, Tamoxifen blocks estrogen in breast tissue, which is part of how it works, but it actually is a partial agonist in bone. So it can actually help preserve bone density, and therefore it does not affect bone density the way that aromatase inhibitors do. Um, it's a partial. Did somebody have a question? No. Okay. So it is also a partial agonist in the liver, which means it has estrogen-like effects on lipid metabolism, which means that it can lower LDL cholesterol. And because of its effect in the liver, it also can contribute to an increased risk of blood clots, the way that birth control or hormone replacement therapy that is metabolized through the liver also can. Um, so after cancer, it is sometimes hard to tell if the symptoms are going to be permanent or temporary, and sometimes it's just anybody's best guess. It may be permanent, it may be temporary, and it may resolve. But generally, factors that affect the risk for permanent ovarian suppression would be certain types of chemotherapy regimens. So lymphoma is one of the most severe and most likely to cause permanent menopause. People who are already kind of a little bit closer to natural perimenopausal age when they're treated are more likely to go into permanent menopause because they've already started to have fewer eggs at the start of their treatment. And as mentioned before, if you are co-administered leuprolide, you may have less of a risk of it being a permanent menopause. So most of the changes that we see as a result of menopause are due to the decline in estrogen, as a result of the changes mentioned before. So as you can see, estrogen has all these different all these different changes. So as estrogen declines, you'll see a decrease in lean mass, an increase in total fat mass, and even more worrisome, a fat redistribution. So instead of having fat on the hips and thighs, it starts to move towards the abdomen and inside your abdomen around the organs, which is called visceral fat. And visceral fat is the metabolically active kind, which unfortunately can lead to insulin resistance, higher cholesterol, increased cardiovascular risk, and overall inflammation. Um, You'll see inflammation changes as a result directly of the estrogen decline. And as a result of all these changes, cardiovascular disease risk increases, as well as just the effects that you're experiencing, your overall risk for disease also increases. So I think we talked about most of these. Estrogen also leads to a decrease in bone density, which can be very steep, especially during the first few years after it declines. And as a result of the estrogen changes in the brain, the insulin signaling changes happen in the brain also, and that can lead to an increased appetite, which is very frustrating when, especially when you're starting to notice some of the fat redistribution changes. It can also be accompanied by an increased appetite because of insulin resistance that's happening in the brain. Not only less muscle mass, but also lower quality muscle mass. So muscle, you know, all other things being equal, does not generate as much force. The mitochondria become less efficient and lower, which can lead to lower endurance. And then if you actually look at the muscle under a microscope, you might notice some fat accumulation between the muscle cells, even though the muscle might look fine visually and look like the same amount. There's actually more fat cells in between the muscle cells, making them function less optimally. And then the way that fuel or food is used changes as a result of the insulin resistance that often comes along with estrogen decline. So instead of sugar or glucose being taken up by muscle, which is one of the largest kind of storage disposal sites for blood sugar, it doesn't get taken up as efficiently because the muscle is insulin resistant. And so then that excess glucose gets more easily stored as fat because not all tissue becomes equally insulin resistant at the same time. So skeletal muscle very easily becomes insulin resistant and won't store the glucose there as glycogen, but the fat cells will often still retain enough insulin responsiveness to be able to store incoming glucose as fat. So it's not that the energy balance is changing, like the body isn't necessarily, it's not creating fat from nowhere, but the same increase in calories will be treated by the body differently. So if you have, 200 extra calories a day, instead of some of it going towards muscle and fat, more of it gets stored just purely as fat because of the changes with menopause. All right, so this is kind of a Debbie Downer, but the specific challenges for cancer survivors is that the earlier loss of estrogen means an earlier exposure to metabolic risk. So somebody that goes through menopause at age 40 is going to have, on average, 11 additional years of loss of estrogen, which further accumulates their metabolic risk factors. Not only that, but the cancer treatment itself may add additional metabolic challenges. I mean, there is going to be more fatigue many times, chemotherapy-related muscle loss during treatment as a result of just decreased recovery and more fatigue, more stress, more sleep disruption, reduced physical activity as a result of all these things. And with the appetite changes from chemotherapy, it may be hard to keep up with nutrition. So harder to kind of get optimal nutritional intake when you're feeling nauseated, understandably. The abruptness of the menopause transition can make symptoms worse. So instead of having many years to adapt, sometimes people could be thrown into menopause within a matter of weeks. So that just leads to much more intense hot flashes and more night sweats, more sudden sleep disruption, sexual dysfunction. It can lead to more mood and cognitive symptoms just because your body is being asked to make this transition, within such a short time. Um, Whether or not the greater cardiometabolic risk, there's greater cardiometabolic risk long term is unclear. So we know that the earlier that you develop menopause, the more risk you have, but that's thought to be because of the extra years of estrogen loss, not necessarily um, due to having the cancer treatment itself. So um, we're not sure if there's like greater cardiometabolic risk compared to somebody who also went into menopause naturally at the same time and same age. Okay, so people who undergo treatment-induced permanent menopause before age 45 and do not receive estrogen replacement, we know have a higher long-term risk of heart disease, stroke, and earlier mortality. But again, it's difficult to separate whether that's from the abrupt estrogen loss versus the longer lifetime spent without estrogen. So, all that to say, if you are able to take hormone replacement therapy, if it's not contraindicated, that is something I would strongly um, recommend considering and at least weighing the pros and cons with your treatment team. It is an option in many cases to take hormone replacement therapy, with the exception of hormone receptor positive breast cancer and some ovarian and endometrial cancers. Um, and of course, this is always an individual decision that's based on personal risks and your own preferences and goals for your health and kind of the symptoms that you're experiencing. But I always encourage people to at least have it in the back of their mind, even if they're not ready to take hormones yet, if it is an option, just to keep that as one very viable treatment alternative, because I think too many women are kind of expected to just suffer silently and put up with these symptoms, and there are some real metabolic risks for them. It's not just a matter of like feeling bad and not being able to sleep and having hot flashes. It's also cardiovascularly, there are a lot of um, downsides to being in menopause. So, if you can take hormone replacement therapy, I always encourage people to consider it. Um, so, if we are not going to talk about hormone therapy, I want to talk now about like the lifestyle options, because there are many really great lifestyle options that can help improve metabolic health. Um, but before I jump into that, does anybody have any questions so far?
I'll jump in with one because I'm very much far down the path of the bad route of
Yeah.
like no ovaries. I'm on exemestane, but I'm about to get off of exemestane. Like, what are the, does estrogen ever come back when I
Yes.
stop some of these?
Yeah.
Like, can it
Yeah.
regenerate or whatever?
Yes.
Okay.
Yeah, it will. And especially since you're younger, or at least you look younger to me. I'm not sure how old you really are,
44.
but 44. Okay. So that you're actually older than you look. No, just, which is a good thing. Um, so maybe, yes, it is harder when you're kind of after 40, I'd say, because you're already probably you would already probably be in perimenopause naturally, but there is a very good chance that it could come back. Yes. Yeah.
Mhm. Okay.
Good question.
I've got a
I have a
question.
question.
There's no way, I guess, to raise a hand in Zoom, is
Yeah,
there?
sorry. Yeah. But
Sorry, I
go
work at
ahead.
Google, so I'm not used to this, but yeah, I just have a question about like monitoring metabolic health and like what potential panels we should be doing, because it's something that my oncologists don't do at all. Like, and I obviously know that there's probably some dysfunction there, but
Mhm.
yeah, if you can maybe talk about that.
Yeah, great question. So I would say for every single person that is in early menopause or in the perimenopausal age range, I would encourage you to at least get the basic lipid panel done every year, to check the LDL, the HDL, and triglycerides. I would encourage everyone to get a hemoglobin A1C, which is a marker for pre-diabetes and diabetes. It can diagnose diabetes also, but it'll also tell you if you're pre-diabetic. And if you are able to convince your doctor to get you a fasting insulin, I would have them check a fasting insulin level because that can change prior to the hemoglobin A1C level. So, getting a fasting insulin can kind of give you an early idea of if your insulin levels are starting to increase. Because if your insulin levels are starting to increase, initially your body can compensate, but eventually your body doesn't compensate as well, and that's when the blood sugar starts rising. Um, if you haven't done ApoB testing, I would ask about ApoB testing. So ApoB is like a particularly high risk particle that is associated with cardiovascular disease. And so getting an ApoB level will give you more information about your cardiovascular disease risk. If you have a strong family history, I would recommend talking with your doctor about coronary calcium scoring so that you can actually get a scan to see if you have any early plaque developing. And the goal is for a score of 0, right? 0 is like best case. You don't want to have any plaque, but that will tell you ahead of time if you're building up any plaque. If you've never had it done, you could get a lipoprotein A. That doesn't really change over time, so you only really need to do it once, but that will give you additional information about cardiovascular risk. Does that?
Thanks.
Yeah, no
Yep.
problem. Absolutely. All right,
I have
so
a question. I'm sorry to interrupt. Were you saying ApoB? What were you saying there?
A
ApoB,
APO
APO, and then
boy.
space
B is in
B.
boy.
Yep,
Yeah.
Okay,
got
got
it.
it. Thank you.
Yep. Yeah,
I
it's
think
it's
that
short for apolipoprotein B, but they'll know if you say ApoB.
I think we had one more question from Lauren too.
Is there, so is it, do you get used to it? Like there's the difference between perimenopause and menopause. And obviously,
Yeah,
if we've been put in menopause, we skipped the period part of it. And so I'm technically medically menopause.
right.
I feel like some of my general, let's not test anything symptoms I've kind of gotten used to or they're
Mhm.
getting better. And then I look at my numbers and I'm like, but these are getting worse. So, like, is
Yeah.
there a difference between perimenopause and menopause
Yes,
in
I
terms
mean, there
of
is a
like,
difference between perimenopause and menopause. So, in answer to your question about if it gets better, the symptoms can get better. Not for everyone, though. I've had patients that had that prior to seeing me had hot flashes for like 8 years before they kind of stopped. So, it's not like they automatically stop as soon as you reach menopause when the periods are done. Like, they can last for a while after. But as far as whether the lipid changes get better and like the insulin resistance gets better, not really, because the estrogen is low. Your body just got used to it, but the reason why the lipids are changing and the blood sugar the insulin resistance is changing isn't changed because the estrogen is still going to remain low. Yeah, good question. All right, any other questions? All right, so we're going to go to my favorite topic of what to do when you are on hormone therapy or off hormone therapy. It doesn't matter if you are on it or off it. I always, always, always recommend that women strength train. This is the single most important intervention you can do for your metabolic and your bone health for the rest of your life. Even if your symptoms abate, I would recommend just continuing to strength train. And it really doesn't have to be much. I think people maybe get intimidated sometimes thinking about, you know, um, these gym bros at the gym that are there like 6 days a week and spending 2 hours at the gym and like dropping their weights and grunting. Like you do not have to do that. I'm talking like 2 or 3 times a week. You can start with like a 20-minute strength workout. Anything that's challenging your muscles progressively is enough. And the great news is that if you're new to lifting, you'll actually have an easier time building muscle and getting benefits with less because your body is just so excited to be strength training. You have like these newbie gains. So the first year or so, you'll notice that you're getting progressively stronger really fast, and it's really fun. So start where you are. If you are, in a situation where you've got aches and pains or you're, um, you know, haven't done it for a long time, you haven't been active, you don't need to start with heavy strength training. You can start with body weight exercises. You can get some physical therapy exercises for rehab, and they can help you with a program. I often write people for physical therapy, and you can ask your doctor just to make the diagnosis deconditioning and muscle loss, and that's a valid reason to get physical therapy. You don't have to have a specific injury. Just make it your goal to keep progressing as you get stronger. So progressive overload, meaning that you add more weight, more sets, or more intensity over time. And if you have questions, you can ask Ashley or Erin, and they will be happy to tell you more about strength training.
Mostly Erin. Erin's the pro.
You can ask them. I'm sure they would love to help you. Okay, and so then the next part of the pillars of how to treat metabolic health is to support your strength training with nutrition. So your goal with nutrition is to preserve the muscle you have with minimal visceral fat accumulation. Most women, 99% of the women I meet in the everyday clinic are not eating enough protein for their goals. So protein goals should be no less than 1.2, but ideally closer to 1.6 grams per kilogram of body weight. And you can adjust that if you're significantly overweight to approximately 2 grams per kilogram of lean body mass. So you can do the numbers and crunch your numbers. It's 2.2 2.2 pounds per kilogram, but practically speaking, about 130 grams a day is generally a good target for an average size woman in midlife. I recommend dividing that up, mostly because practically speaking, literally no one's going to be able to get away with eating one meal a day and getting that amount of protein. Your digestive system just literally could not handle it. And many of the women that I meet are skipping meals, so that makes it even harder to meet your protein goals. So ideally, if you can eat 3 or 4 times a day, divide that protein target that you're shooting for into 3 or 4. I always shoot for 4 because 3 meals a day, even like 40 grams of protein is a lot for a breakfast for me. So, and try to get that every single day. Protein does not get stored the way that carbs and fat do. You kind of have to do it every day. So you can't just like eat a million steaks on Sunday and then be fine on Monday and Tuesday. That's you need it every single day, most days.
I have a quick question here, and I
Mhm.
just like I feel like because this is like the talk of the town, right? Like GLP-1s and peptides and all of that, and like that almost feels like it's defeating a little bit of the purpose of what you're outlining here of making sure you're getting enough nutrition. Because again, I
Yeah,
know people who take them, and I think it makes their appetite suppress a little bit based on my
totally.
understanding. Is that
Totally.
is that kind of like how do you look at that?
Yes, you're getting into one of my very favorite topics. So I absolutely prescribe GLP-1s for my patients, but I will not prescribe it unless they can commit to eating their protein. Because what happens if you're on a GLP-1 and you're getting appetite suppression, which is 80% of how that GLP-1 works. So 20% of it is improving the insulin resistance. In terms of weight loss, that can help with fat loss, but 80% of the effect is from the appetite suppressant effect, why people lose weight. Um, if they cannot maintain their protein intake, and especially if they're not strength training and not maintaining their protein intake, they will lose almost up to half of the amount of weight that they're losing is muscle. And that is a metabolic wasteland, like especially for people that are getting older or already frail, but they're like obese and frail. It can be really problematic in terms of their muscle and strength loss. And you're right that I think that it's harder to eat a few times a day with GLP-1s, but actually since they fill up earlier because of the delayed gastric emptying, actually eating more frequent meals is recommended, frequent smaller meals. So then I might even have them eat like 5 or 6 times a day just so that they can get the protein intake in that many times a day and they're getting their overall protein intake, but they're not stuffing themselves because they're not going to be able to eat as much in one sitting because their stomach is just not emptying as fast.
I just have a question about the GLP-1. So what's the research around like why people are getting like sudden eye stroke? Because that to me puts me off. Like I know the risk is very low, but the outcome is very high if you have that. So it's difficult for me to want to do that.
So I don't know that we know why they're getting the sudden eye stroke. Are you saying eye stroke?
Yeah, the Nion, like the optic neuropathy where they're going blind and like it's not like reversible. Like the
Gotcha.
sudden blindness.
So
Yeah.
we don't know why. And it's not, I think it's overblown. I mean, I know it is concerning if it happens, but it happens in like 1 in 10,000 people, versus in the average population, it happens in 1 in 20,000 people. So yes, it doubles your risk, but the risk is so low that that would hardly ever be a reason I would have someone consider not to take it, because the absolute risk is so low. That being said, we don't know why it happens. And there are some things about these drugs that we just don't know why. I think because they're so new, they
Yeah, I
just
was gonna say they're so new.
they're so new. Yeah, I mean, they've been used for diabetes
Mhm.
for a lot longer, but we have not had them used for weight in this way. I mean, and they're just being used everywhere now. And I think we're going to just kind of like learn as we go. And the, I mean, I hate to say this, but like when you're treating people for diabetes, like they're going to have eye complications anyways, and they have all these
Mhm.
Yeah.
things. So people may not have even recognized that this was related to the GLP-1. They're like, well, they just had it. They're sick. They're a poorly controlled diabetic. So yeah, good
And
question.
Nicole, hi.
Hi.
What about the like they're coming out with the cancer protective like reducing systemic inflammation,
Yeah.
and they're starting to say that GLP-1s are actually potentially positive for our community. Like,
Yes.
do you have thoughts on that?
Yeah, I think it's really promising research, and I have seen that, and it makes sense. And anecdotally, I've heard just like so many reports of people feeling like inflammatory symptoms are better. So I do
Mhm.
think it's the anti-inflammatory effect, of these medications that are helping with that. It's not indicated yet, like we don't have enough research to
Mhm.
use it just for that specific indication, but I think it's a very positive, potential side effect. Yeah. Yep. Good question. All right. So, let me see. I'm losing my slides. Okay. So, going back to nutrition stuff, we talked about protein. We talked about dividing it into 3 or 4 meals. The second thing that I want to talk about with nutrition, and this also gets harder with the GLP-1 because you're going to be full when you're doing a lot of protein and fiber. But in general, for metabolic health, you want to make sure you're getting enough fiber, from plant sources. So beans, soybeans, chickpeas, berries, lentils, oats, chia seeds, broccoli, and barley are some of the best sources. But the goal is to get at least 25 grams of fiber daily. And I actually have people, if they can, aimed for 30 or more. The 25 is like the minimum, but 30 is great if you can get 30 grams of fiber a day. I bolded the oats and barley, because these ones also have soluble fiber, which is especially important for cardiovascular health. So make sure you're getting a good combination of, insoluble and soluble fiber. It'll label it on the package sometimes so you can see, or you can just Google, soluble fiber. But those high fiber foods are going to improve LDL. They're going to improve blood sugar control, improve gut health, and decrease inflammation in your body. So all great things. The the only difficult thing is getting enough because it's fiber is really filling and protein is really filling. So by the time you hit your fiber goals and your protein goals, there's not much left in your stomach sometimes. All right.
Quick question since so I often my LDL is generally fine, but my HDL is generally low.
Mm,
Uh, is that more like a, something that could be mitigated with nutrition as well?
harder. It's harder with nutrition. Alcohol improves HDL, but I don't recommend alcohol. Yeah, I mean, that's probably just from the estrogen being low, I'm guessing,
Okay.
unless it's genetic. Exercise
Yeah,
modestly improves HDL, but I know you already exercise. So that's probably more related to the estrogen, I would guess.
interesting. Okay.
Yep. Lifestyle options. So in addition to strength training, obviously walking and aerobic exercise are great for your heart. Most of it needs to be around moderate intensity. HIIT is controversial, and a lot of people just aren't even up for HIIT. It just doesn't feel good to their bodies. It causes a lot of joint discomfort, and it might impact recovery and sleep if you're doing too much of it. But if you like doing it, and you want to maintain your VO2 max, one session of HIIT a week is generally plenty. And you can do up to two if you're like very low stress and well recovered and sleeping great. And you don't need to do much of the HIIT. Usually like 10 minutes of high intensity work is plenty for most people. So
And
aerobic, yeah, go ahead.
there's some, so the difference between HIIT and then sit, so the like sprint interval training versus HIIT, there's some better data on the sprint interval training for like overall stress and
Ooh, tell
better
me.
recovery. Yeah, so there's some because the sit is more like because HIIT you think of like the EMOMs where you're like every minute on the minute or you're like the really high like I think like the CrossFit workouts and stuff.
Mhm.
But sit is like you do a high intensity sprint and then you fully recover from it. And then you do another high intensity sprint and then you fully recover from it. And they
Oh,
say like
That's what
six
I
to
mean
eight
by that's what I mean
hit.
by hit.
Okay.
Yeah, yeah.
Okay.
I don't do the CrossFit style stuff.
Yeah.
That's really taxing, I find. Like the Orange
Yes.
Theory stuff. So the sit
Hmm.
is good. That's what
Yeah, so sit
that's
is better than how like the hit is defined
yeah.
because of that longer recovery window between
Yeah.
sprints.
Yeah,
Hmm.
I guess what I'm calling hit is what I tell people to do, but it's
Yeah.
actually sit.
Yeah. Sit.
Yes.
Yep.
Yes. Like a minute of like hard, like 30 to 60 seconds of hard, and then
Yeah.
like a full 3 minutes or so of recovery.
Hmm.
Yeah.
Yep.
And you don't
Yep.
need much. You really don't need much
No,
to
it's
get those
like you can
benefits.
do like they say like 6 to 8
Hmm.
bouts. Yep.
Yep. Yep. Yep. Perfect. I love that. Awesome. I'm glad that you clarified that because, yeah, hit. I don't mean like the Orange Theory hit classes where you're doing like everything on the minute for an hour. I think that's overkill for a lot of people. If you like it, great, do it once in a while, but just be cautious of recovery. I keep switching my slides. Hold on. Here we go. All right. So going back to recovery, so sleep optimization. So that is a very underappreciated aspect of metabolic health. And it is really challenging because sleep is disrupted by changes in estrogen. So poor sleep, unfortunately, will directly impact insulin resistance and your ability to recover and your mood and motivation, which makes it even harder to follow some of these lifestyle guidelines. And it is associated with visceral fat accumulation. And I didn't write this, but actually, sleeping poorly is going to make it harder to build muscle also. So there are so many reasons why sleep is so important. So I tell people, even if you can't take hormones, if your sleep is disrupted by hot flashes, like get something for your sleep, get something for the hot flashes so that you can sleep. There are many non-hormonal hot flash treatments that you can take. Experiment with them. Some of them work for some people, some of them don't work. One of the best well-known ones that I've had people have success with is Viaza. Linqued is similar to Viaza, but it's newer, and I don't know if insurance always covers it, but Viaza should be covered if you have a contraindication to taking hormones and want something for hot flashes. Also, some SSRIs and SNRIs can be used off-label for hot flashes. And then gabapentin has also been used by some people for hot flashes, and it also makes you drowsy. So that sometimes helps people, although I feel like sometimes people get groggy on it too, which isn't great. Sleep hygiene, of course, like keeping a dark, cold room, avoiding screens and stimulation before bed. We had thought that like blue light was a big contributor to the sleep issues. Now it's thought that blue light isn't necessarily the only reason or even the major reason why people aren't sleeping, but it's more the stimulation of what you're watching with the blue light that's more problematic. But it doesn't hurt to wear some blue light blocking glasses if you feel like you're particularly sensitive to light and just dim your light as much as you can. So I feel like my whole family yells at me because I just turn all the lights on dim in our house and I have like only ambient lighting, not overhead lighting. And I've changed all the bulbs to be red. So they're like only putting out warm red light. And my husband's like, we look like we're like living in a horror house, but I swear it helps. And so if you want to get some cheap red bulbs on Amazon and like just dim your house and create an ambiance, that may help. CBTI is the most well-regarded treatment for chronic insomnia. So it's hard to find someone, but they have some online programs that you can do if you are having trouble finding cognitive behavioral therapy for insomnia. And then just make sure to give yourself enough hours in bed. That's my problem, because you actually have to be in bed for these things to work for enough time. Even if you have great sleep quality, if you're only sleeping for 6 hours, it's probably not enough. And it takes on average 20 to 30 minutes for a normal sleeper to fall asleep. So just make sure you're in bed for at least that 8 hours if possible.
I had a
I'm sorry to
question
interrupt again.
about,
Oh,
oh,
sorry, Jen.
sorry. Oh, sorry.
It's Jennifer. I just wasn't sure about the spelling of, did you say Yowza?
Yowza, yeah.
How do
Yep.
you spell it?
It is Y, or I'm sorry, VEOZAH.
VAO
VEO.
Okay, thank you.
This one, VEOZAH. Yep, you got it. And again, Linkuet, let me know if anybody tries Linkuet and gets insurance approval for it, because that's like supposed to be the newest one that works even better than Viaza, but I've not heard anybody getting covered for it. But their reps assure me that it should be covered for somebody.
Could I ask you a question about gabapentin?
Mhm.
So I've taken gabapentin off and on for a variety of reasons. But my oncology team, the last time they prescribed it to me, they basically said that people were viewing gabapentin as almost like a narcotic now, and they wouldn't just keep prescribing it. But then I'll go to somebody else and it's like, sure, have some candy. So I was a little confused because I have gabapentin definitely helps me with sleep. So I was just curious if you had heard anything about that, because I just thought that was weird.
So it's not addictive the way that opioids can be, or like
Yeah.
controlled substances. Maybe they're concerned because it can cause that drowsiness and kind of like unsteadiness, coordination problems. And then at like higher doses, it could cause some respiratory depression if you're taking like a lot of it. But I will say that I prescribe it all the time.
Yeah.
And if you're, I mean, the range of what you can treat with gabapentin goes up to such high levels that like if you're taking like 300 a night, that's very unlikely to
That's
cause
all
it.
I was taking.
Yeah,
And I only
I
took
would
it
not worry about that.
at night. Like
Yeah, that's nothing. I've had patients that are on
okay.
like 900 three
Okay.
times a day and they're
Yeah, no,
walking around just
I
fine.
only take
Yeah.
it at night pretty much for sleep,
Yeah.
because that's one thing that helps me sleep.
No, I don't see any
Okay.
reason
Okay.
why that would be controlled.
I'm getting it
Ambien,
fixed
Yeah.
yes.
then.
I would get worried
Yeah.
about Ambien, but not about
Okay.
gabapentin.
Okay.
I think, I mean, so I work in spinal cord injury also. We have a lot of people on like a lot of gabapentin, and I think the worry is like the physical dependence, but at the higher levels,
Yeah.
and then like withdrawing from it if you're trying to get off of it. But at your dose, Jen, I don't see a problem either.
They're getting a call today.
Shoot. Don't tell them I said anything, but yeah, I mean, I think that's pretty low risk. And if it helps you to sleep and it's just that, I don't know. That seems much better than Ambien. Okay, so supplements. I don't generally think that any supplement will come anywhere close to the benefits of all the other stuff we talked about. But that being said, like if you're already doing all that other stuff and you kind of want to add a little bit of extra, something you might consider is psyllium husk. So psyllium husk has a lot of soluble fiber in it. And so if you're finding it hard to meet your fiber goals, you can mix it with water or drink or in your smoothie, anything with liquid. And you can take, anywhere from 5 to 10 grams a day, and that will help with your cholesterol. And it's cheap. You can get it anywhere. Whole Foods has it, I believe. And then protein powder is probably one of the most helpful supplements if you're having trouble meeting your protein requirements. I would just recommend that you get a high quality one. Just if you're going to be using it every day, try to get something that's, third party tested. Whey protein, if you can tolerate dairy, is a great one because it has a good amount of leucine in it, and there's no risk of like the heavy metals and ground contamination that you have from some of the plant-based proteins. So if you can do whey protein, great. I would say that one's probably a great one to do, like a grass-fed whey protein. Soy protein is also an option. There's lots of proteins. Creatine is a little more controversial, but a lot of people take it, and I feel like it's like the trendy new supplement now. And it works best when you're also training. So just taking creatine alone isn't likely to give you much of a benefit, but if you take it consistently, you may notice improved training adaptations, increased strength, and then overall, indirectly some increased lean mass with good quality training. And then there's some newer studies that suggest potential benefits for bone health and cognitive function. These are a little less well defined, but there are potential, interesting possible benefits from it. It does tend to upset people's stomach when you first start. So if you were going to start it, first of all, I would always clear it with your doctor and let them know, because it will increase your creatinine level, which does not mean that you have lowered kidney function. It just does that as a result of the components of the creatine. But if they see your creatinine go up on lab work and you haven't let them know that you're starting creatine, your doctors will worry that you have reduced kidney function. So there are ways of testing your kidney function that don't involve measuring creatinine, but they're a little less common. So you would just want to let them know that you're on creatine. And then if you have high blood pressure, oh, go ahead.
Is that the same with BCAAs
No,
if they are mixed with them? But it would be the creatine that
it's the
would up
creatine.
it.
Yeah. But I don't know if you guys have heard, but I have heard that the BCAAs don't work as well from what Aaron, do you know anything about, like, BCAAs aren't really building muscle as much as like the actual protein supplements.
Yeah, same. It's like we already have enough if you're doing all of the, yeah.
And they taste
I don't,
terrible.
yeah.
They're so gross.
One that's like mixed, it's a BCAA and a creatine, and it's actually tolerable and I don't mind it. And so I was like, okay, but again, I've had one doctor say, oh, well, your kidneys aren't functioning. I'm like, did you listen to the part where I say I work out and this is what I do? So
Yeah. It might be the
um
creatine. It might be
yeah.
bumping up
Hmm.
your
Okay,
creatinine. Yeah.
got it.
Um,
Thank you.
yeah, no problem. So creatine, 5 grams is like the average dose that most people take daily. You don't have to do a loading dose if you take it every single day. But if it's upsetting your stomach, 3 grams is plenty. And then it's even more something that I suggest if you are a vegetarian, just because creatine sources a lot of times are in meat. So if you don't eat meat, you might not be getting enough natural creatine from your diet. Omega-3 fatty acids in fish oil have cardiovascular benefits. They don't necessarily change your lipid numbers, so don't expect them to change like the actual numbers on your cholesterol, other than it might decrease triglycerides a little bit. But it does change the inflammation environment in your body. So even if it doesn't change your numbers, it actually is doing something in your body in terms of improving your cardiovascular risk. And I would talk with your, team about how much to take, but usually it's more omega fatty acids than you think. I'd say like 2 grams is usually a good dose. And if you look at how much is actually in your supplements, that might be like 6 or 7 of those, like less high quality omega 3s. And then some of the higher quality ones, you might need to take 2 of them. So just actually calculate on the back of it how many omega 3s are in a serving, and probably try to get closer to like 1.8 to 2 grams. All right, so for bone health, these supplements are helpful. Vitamin D, magnesium, calcium. Vitamin K2, again, is like pretty trendy, but we don't know for sure if it's necessary. but if you want to take it, it's not going to hurt. Calcium, you'll want to get at least 1,200 milligrams from all sources, and you'll want to remember to divide that up. You don't want to take it all at once because it can't be absorbed all at once. So dividing it into 2 or 3 daily doses is a good idea. Vitamin D you can take all at once. And even some people, if they're low, can take it weekly, just so they remember. And then if you haven't been tested on vitamin D, I would recommend that you get tested every year. It's a cheap test, but it's not always offered. But there's really no way to know if you're low, like you don't have symptoms from it, or they're vague symptoms unless you get tested. So ask for a vitamin D test every year. And then once you've done like a higher supplementation dose, like if you were low, get retested again. So 3 months after being on high dose supplementation. That way you can decide if you need another round.
And they are, Nicole, have you seen not necessarily causation, but correlation of chronically low vitamin D and then cancer risk or like other, um,
Yeah, I mean, I have heard that. I have
yeah.
heard that. And then also with like multiple sclerosis, but we don't know,
Hmm.
yeah, we don't know what's causing what. And so like
Hmm.
I see low vitamin D in a lot of people that just aren't eating well, that aren't like absorbing well. So they may have those things that are also impacting their cancer risk. So it's hard to say which
Hmm.
is which. But I do notice that when people's vitamin D gets replaced, their energy is a lot better. So
Hmm.
that I think that alone is worth it. And then just for the bone benefits also because of the risk with osteoporosis, just making sure your vitamin D levels are topped off is a good idea.
Hmm.
Um, yeah, good question. All right, so I think that's it. But in summary, if you can take HRT and you are experiencing early menopause, at least consider it and talk about it and think about it and research it. No matter what else you do, please do some form of resistance training and nutrition, sleep, aerobic exercise, and sometimes supplements can help and are also good adjuncts to the resistance training. So I know we've talked, already quite a bit, but does anybody have any questions or anything they want to talk about? I'll open it up to you guys.
If I'm going to a primary care first time because I feel like my numbers, I have blood work from May and I have extensive pre-breast cancer blood work. So 6 years ago versus May, and I showed them my numbers and I say, yes, I'm on Lupron and Anastrozole. Is there anything else that I should tell them to have them help me in the best way possible? Does that make sense what I'm asking?
Like to help you kind of maintain I mean, bone density testing, that would be
Bone
one.
density is good. It's more of the cholesterol and the insulin that have gone up. And
Okay.
I don't know that I want to be on a GLP-1 because I do like to lift and I work out all the time. And so I like to eat. I feel like I've done pretty good of making it healthy but I don't want to not eat. Does that make sense as well? Like I
Yeah.
don't want them to just say, here, take a GLP-1 because that's
Right.
not, I would like to be on the least amount of medicine possible.
Sure. Yeah. I mean, I think
Like, is there
that's
something as a doctor that you would like more from me as a patient to say, or is that kind of enough to give you some guidance?
I think that's enough to give me some guidance. I mean, I would want to know exactly how much exercise you're doing and exactly what you mean by eating pretty well and kind of like dial that part in if you wanted to do it through lifestyle, which I think is totally possible, just harder. Um, but knowing that you might do everything possible and your LDL still might be a little high just because
Yeah.
maybe you have a combination of genetics and family history, and that's going to influence your LDL. And then plus you have the menopause thrown in there, and that's going to influence your LDL. It may just be high. But that being said, you can mitigate some of your risk by doing the other stuff too, right? So exercising and eating well, limiting alcohol, not smoking, doing all those things are also going to mitigate your risk, keeping your blood pressure in a good range. So we don't prescribe statins, we don't prescribe cholesterol medications, or we're not supposed to based just on your LDL numbers unless they're sky high. But if it's just a little bit high, then we calculate your risk based on other things too, based on your ethnic background, based on your smoking status, and then we decide like, are you at high risk for a heart event? And then we would talk about whether or not you needed to be on a cholesterol medication.
Got it. Thank you.
Yeah, absolutely.
I have a question too.
Sure.
Do you do, I don't know if you said this and I apologize if I missed it, but do you do any virtual consults, for us if we were interested in working with you directly? If we could
Yes.
share
Yeah,
our blood
yeah.
work and
Yeah, absolutely. But so I'm licensed in Colorado and Maryland. So for virtual consults, if it's if it's with lab orders and like lab testing and prescriptions, you would have to be located in Maryland or Colorado at the time of the consult. You don't actually have to live there, you just have to be there. It's a very strange rule. But for other clients, it's a different thing, but I can do consults and I can recommend lab testing and I can recommend things, but I can't prescribe or order tests in a different state. Yeah.
okay, thank you.
Absolutely. All right. Well, I think we're almost at time, but my email's up here if you think of any questions after the presentation, or just want to say hi and let me know how you're doing. hello@nicolerowe.org. And I have really enjoyed talking to you all today. Thank you so much for the great questions and your attention. I hope it's been somewhat helpful. Hopefully I didn't get anybody's doctor in trouble. Sorry to Lauren's doctor. Yeah,
Oh, this has been super insightful. So thank you. Very helpful.
yeah, you're welcome. All
Awesome.
right. Well, I hope you guys all have a wonderful Friday. Thanks for having me here. And
Yes.
Thank you. Glad
Thank
this
you.
worked out and we were
Yeah.
able to make this connection. So,
me too. Me too.
and you're
Thank
going to
you.
be hearing from me, Nicole, by the way.
Okay, sounds good. I would love to. I would love to hear from you anytime. All right.
Awesome.
Bye,
All right. Thanks,
everybody.
everyone. Bye.
Bye. Thank you.
Bye, thank you.